TMS, which is transcranial magnetic stimulation, and the other one being a nasal esketamine called Spravato. So welcome, and thank you guys for taking the time out of your day to join us. Today we have presenting Dr. Anish Shah and Jessica Schmidt, psychiatric nurse practitioner. So if you want to give a warm welcome, Dr. Shah, you're up. Yeah.
I want to welcome everyone for attending this webinar on novel treatment for clinical depression. We have a large population of patients who have struggled with clinical depressions. And as you know, in depression treatment, the conventional treatment are medication treatment, psychotherapy, group therapy, ECT treatment, and treatment likewise. And today we are going to talk about two treatments which are evidence-based and FDA approved. One is transcranial magnetic stimulation and nasal esketamine. We are here to inform you about this treatment, and if you have questions at the end of the presentation, we will take all the questions. So please make a note of your questions, and I and Jessica will try to answer. And the way we want to do is we'll first do the TMS presentation, and then we will do nasal esketamine presentation, and we will take questions about both treatment modalities. So I again want to welcome everyone. By way of introduction, I'm Dr. Anish. I'm the psychiatrist, medical director for Siyan, and we established Siyan in 2012. We have been doing TMS treatment since 2016, and now since last year we have added another FDA-approved treatment, nasal esketamine or Spravato, which is utilized for treatment-resistant depression. This is our lovely team of TMS technicians and also Spravato technician. They will also be presenting about the logistic part about getting this. So round of applause for our technicians and providers. They do a good job in building relationship with patients, making sure their insurance authorization, other. And then you have a smooth journey to the treatment. So they are a very important part of our team in delivery of treatment and monitoring on a daily basis. Again, this is my disclosure. Again, I'm a Dr. Shah, medical director. I do not have any interest in any of the drug manufacturing or pharmaceutical companies' stocks or investments. I do not have any other contract or engagements of that nature with them. And I also have no stocks for manufacturing for TMS devices. A disclosure. I'm going to talk about TMS treatment, and my colleague Jessica is going to speak about nasal esketamine or Spravato treatment. And again, how many of you have heard about TMS? If I can have a little hands here. So I believe we have close to 30–40% of the people who have heard about TMS. Okay. Yes. Okay. All right, heard a little. Okay, so transcranial magnetic stimulation definition is non-invasive method of neuromodulation or neurostimulation. And if you look at here, you will see that there's a coil. And if you look at my cursor, and this coil delivers a magnetic or magnetic current, which gets discharged into electrical, which ultimately through a large capacitor into a coil to produce a pulsated magnetic field. And then this magnetic field pulsated targeted area in the brain. And in here we are going to target the left prefrontal dorsal cortex. And what it does is it depolarize or hyperpolarize our neurons in the brain. So just to explain that in some simple term about what the depolarization of neurons is, when we have depression, when patients have struggled with depression, you may have heard this term from many of your loved ones. We feel like a fog, we feel like our brain is not active or it is as sharp as it used to be. A lot of my patients will come and tell me, I feel I can't remember, I can't think. I have to always make a little list. If I go to a grocery store, I have to keep a list. Otherwise, I can't remember what I'm expected to do, even if I have 4 or 5 items to get. When I go to a room, I sometimes forget why I was there in the room, and that is a classic symptoms of depression because the brain is not firing as it should fire. It's because our brain cells, which we call as neurons, the synaptic connections, the connection between them is So what this treatment does is it stimulates those synaptic connections, by utilizing or delivering a magnetic pulse, which gets converted into small electrical impulse. And that is precise mechanism of action of TMS. Next. Now, TMS treatment, again, during a TMS procedure, like I said, electromagnetic coil is placed gently on the scalp of the patient. So there's a coil which gets applied in your left prefrontal dorsolateral cortex. And you can see that in the picture here, this is how the coil is applied. Coil is connected with a pulsated generator. And then here is the generator. And that delivers a charging electrical current to the coil. It uses a rapidly charging magnetic field to stimulate neurons, which I just spoke about, activating neurons. And then this magnetic field produces electrical stimulation, which penetrates 2 to 3 centimeters into the brain at a targeted site. And targeted site here for depression treatment is left prefrontal dorsal lateral cortex. So this is a little bit about history of TMS. Though TMS is approved in United States in 2007, 2008, it has been in research for many, many years. Just in 81st in 1831, a lot of you who are interested in history would know that Faraday first talk about electromagnetic field. In 1970, clinicians started. 1970 was the first year where clinicians started using transcranial electric stimulation to diagnostically measure motor conduction time in patients suffering for multiple sclerosis. So TMS treatment in 1970 for the first time started for multiple sclerosis patients. And then the research evolved over a period of time, and then Anthony Becker and his colleagues came into 1985. In 91, it was they started to use in neurology field, and then in 94, the RTMS, the current treatment started to get into practice for to assess the cognitive effect. And in 95, for the first time, the first clinical trial that was conducted on 15 patients suffering from drug-resistant depression. Drug-resistant depression means where the conventional medication treatment, that's where the treatment was first conducted in 1995, and that trial showed some promising results.
Can you repeat what you said? Just said the drug. drug DRD, what it was. I need to write that down.
Okay.
Sorry.
I'll take all the questions later, but before I take your question, can you repeat what you said?
You just said drug-related depression or something?
Yeah, treatment-resistant depression. What I said is treatment-resistant depression. So treatment-resistant depression means, by theory, when somebody has more antidepressant and it has not produced the results. It has not helped reducing the depression 50%. That is the definition of treatment-resistant depression. And then TMS first started getting used in Brazil, Canada, Australia, some of the European countries first, and then ultimately it started to we started to use it in the United States. So in 2008 consensus conference was the first time where all the scientific community came to a consensus about what is a treatment parameter to use for treatment for depression. And in 2007, like I said, was the first time that FDA TMS for after clinical trial of 301 patients. So FDA clearance for TMS has been since 2007. And this is a slide about medication studies on and its efficacy or effectiveness in patients with depression. And the study is called a STAR. This was a very big study. This was done in 2006, and then and multiple sites across United States enrolled patients to this in this study. And this study was designed to see efficacy of antidepressant treatment and also look at sequentially what antidepressant is going to be benefit and in what algorithm the antidepressant should be used. And if you look at the study treatment results, the slide here shows that when somebody uses antidepressant the first time, when they use, it's more efficacious. And then when the depression comes back again, they use again. If they have a one failure, then there is about 21.2% patients who sort of there's 21.2% patients who do not respond. And then somebody who has two failure, there is even less patient who respond. So sequentially, when someone has used medications before, the subsequent medication trial of a response which the previous medication trial may have used. It's because our brain gets adapted. The use of antidepressant over a period of time do not yield the same results when you use sequentially newer drugs, and this is very common. Patient may respond very well to sertraline in 2002. Again, in 2005, when the sertraline didn't work, they tried venlafaxine. The venlafaxine kind of worked, but it did not work. And then once they used 3 or 4 medication, the subsequent antidepressant did not yield the results that they are looking for, So this is again a study trial, and this trial also kind of measure some of the side effects which you may have either heard or experienced or seen in your loved ones. The common side effects with a lot of antidepressants are weight gain, constipation, diarrhea, nausea, drowsiness, insomnia, sexual problems is another issue with antidepressants, anxiety, appetite changes, and then fatigue, headache, sexual problems, tremor. And part of it, why this side effects occur, because most of the medication get absorbed through gut, it goes to your liver, kidney, and it has a peripheral impact before it crosses blood-brain barrier and goes to the brain. So by the time it reaches to brain, it has a peripheral effect, and this peripheral effect causes side effects. Now, antidepressants and other treatment are helpful, and don't get me wrong here, and they should not be stopped if you MS and so forth. But the fact is that our patients and we clinician are often with the side effect profiles. We are still looking to get cleaner and cleaner drugs with a much favorable side effect profile. So this is another scan that I want to show you, and then in this scan you will see two pictures. One is, and this is a PET scan, PET imaging scan, and it shows one, and second one is the depressed brain. So this is a depressed brain, and this is how the depressed brain looks when you do the PET study, and this is the normal brain. Now, why the brain is like this when we have depression? It's because when we are depressed, there are 3 or 4 things happen in our brain. One is the blood glucose, oxygen, and the metabolism that our neurons need is shunted. Shunted means it's sort of underactive. So the brain cells do not absorb glucose. They do not get as much oxygenations in a late term. They don't have all the metabolic nutrients that we are really, which are really useful for healthy, normal function of the brain. And on top of that, there are other things that happens. And that's one of the hypotheses is when serotonin, norepinephrine, all these neurochemicals, these are the chemicals which generally make someone feel better, they improve their mood, but the scavenger cells between the synaptic cleft eats them. So the reuptake is sort of impaired, So this is the reason, there is a reason. If you look at the PET study of a depressed brain, you will see the brain doesn't have this bright and shiny signal that you see on the normal brain, and the depressed brain is sort of, right? And which I just used the term before is like a cloud. It's a cloud on your cloud hanging when you're depressed. So when we are talking about neurostimulation, there are 2 great treatments, and they both work very well. One is TMS, and second is electroconvulsive shock treatment. ECT treatment, though, has a lot of stigma, is also a great treatment. It's also a treatment, evidence-based treatment for people with severe depression. Severe depression means people with depression with some paranoia, psychotic features. Some people with depression will stop eating, they will lose profound weight. They also have difficulty moving or speaking, which we in a clinical term call as psychomotor retardation, where your physical activity is slowed down. ECT is a great treatment. Unfortunately, with ECT, there are few setbacks. The number one setbacks is in state of California, you need 2 psychiatrists to approve treatment. Second setback is there are not very many ECT centers. We have one center in Marin County, there's one in San Francisco, there's one in Sacramento. So there are not very many ECT centers for our loved one. And we would love to see more and more ECT centers open. Third thing about ECT is you need support. Patients need support to get an ECT. So, ECT is done under anesthesia. So essentially, a psychiatrist evaluates, you go for a course of treatment. So you have to have someone who you drive you to the ECT centers, or you get admitted into inpatient unit. Then you receive the course of ECT, and then somebody has to drive you back because of the effect of anesthesia and ECT treatments, patient cannot drive. So that's another setbacks. And one of the biggest complaint about ECT is when somebody had sequential ECT for prolonged period of time, there is memory issue. There is a cognitive problem. So basically, patient receiving ECT, it's very common to see memory and concentration issue for 4 to 6 months. And most patients generally do well after that, but that is one of the side effects that most of us hate, the memory and concentration issues. Otherwise, ECT is a good treatment. Now, if you compare the other neurostimulation treatment, TMS with ECT, TMS also is a neurostimulation treatment. However, the good thing about TMS is that there is no second opinion required. Most of the patients go to TMS centers driving. They just go receive treatment and they come back. Most of the treatment patients, while receiving treatment, they read a book or have an iPod or something like that, so they don't have altered mental status, and it's reasonably safe way of receiving treatment without an external assistance. And then side effect profile with TMS is very well. And TMS doesn't cause any long-term cognitive issues, as I've said. Now, if you look at TMS impact, and I will go through some of the clinical trials done on TMS as well. So they did a 7 meta-analysis. When I say meta-analysis, means it's a pool from various clinical trials. So a researcher will review research data from several TMS trials, and then they will aggregate the data, and then they'll determine if the data shows if the treatment is efficacious or not. So there are about 7 meta-analyses which studied TMS versus sham. Sham means placebo, placebo TMS, and which they showed positive impact of TMS on clinical depression. The impact of TMS on one's after it benefited, the results were durable. Durable means the results lasted for a year. So after somebody received a course of TM for a 1 year, the results were lasting, and there were no long-term side effects. So this is the most important part about TMS versus medication versus ECT. TMS doesn't have any systemic side effects. So when I say systemic side effect, it has no issue with weight gain, weight loss, sexual dysfunction, cognitive problems, night sweats, headache. Headache can happen. That's one thing when you are receiving treatment, but long-term headaches, that's what I was referring to. The two common things with TMS is there is a potential theoretical risk of seizures, conversions. So it's not a good treatment for somebody who has an active convulsion, active seizures. And it's because it decreases the seizure threshold. However, if you have history of seizure and it's been treated, it's a safe treatment to do. And second thing is, the way TMS is delivered, it does cause scalp irritation. Some patient might experience mild headache. And then I'll go through contraindication of TMS. Basically, if you have a metal clip or aneurysm plates or some sort of a metal in your brain or close to the sites, the metal gets heated. And those are not a good candidates for TMS. So this is again a randomized clinical trial which involved 301 patients at 23 sites, and Madras is a depression scale, and they found 22.1% reduction in depression scale in this clinical trial. And overall, the open label extension means first they do a placebo control trial, and after the trial is over, they have the patients, either they have received placebo or they have active arm of the treatment, get an extension of the treatment where they actually get TMS. 1 of 2 patients responded, and 1 of 3 patients achieved remission. When I say 1 of 2 patients responded, means their depression score is measured by PHQ-9. Some of you have done PHQ-9 at the score at the patients, at the clinicians' offices, or back depression inventory score. Depression score goes by half. That's called as response. So your depression, in essence, 1 in 2 patients in this clinical trial have their depression reduced by half. And about 1 in 3 patients achieve remission. Remission means the depression score on PHQ-9, which is one of the measure for depression, was less than 6. Basically, then remission means 80% of their depression was gone. That's a definition of remission. The response definition is 50% reduction of symptoms. the definition of remission is 80% reduction of the symptoms. So 80% of the patient, 1 in 3 patient had remission, and 1 in 2 patient had response. And it was safe when they did a safety study for 6 months. This is another NIMH funded study. So this is independent of industry funding. We all have our own biases about industry sponsored clinical trial, but this was actually by NIH, and they had 190 patients and 4 premier academic sites. Academic site means UCSF or some of the big institutions where there is an academic affiliations. And then they had a active arm and they had a placebo arm, and odd ratio of achieving remission was 4.2. Then 30% of the patient achieved remission in open label extension. So this is again the consistent data on a non-industry sponsor or NIH sponsored clinical trial, where 1 in 3 patients, 30% is approximately 1 in 3 patients achieved sort of remission, means 80% reduction of the symptoms. And excellent safety profile, nearly 90% of the patient adherent to acute phase of treatment. So 90% of the patient did not report any problems in the safety data. Okay, long-term follow-up after acute treatment. So during open label follow-up of an antidepressant medical therapy, 37% of the patient required TMS introduction, 85% of the patient who received TMS introduction benefited. So basically it says depression life situation happens if patient responded to TMS, and then maybe 2 year down to the line, 3 year down to the line, or if you have a serious depression, you can do TMS again. And then in this clinical trial, they have showed that 85% of the patient who received TMS again got benefited. So, and at Siyan, we may have done about 270 patients, and handful of the patients we have done a second and third course as well. But those numbers are, I would say, roughly less than 60 to 65 out of 270. So TMS also has a research studies and interest in other disorders. Though it's FDA approved for clinical depression, but people with anxiety, OCD, PTSD, substance use, schizophrenia, the TMS has been currently studied, and there are active trials on this disorder also. TMS for anxiety disorder, more research is needed in this area. However, there are good data that shows that TMS works and helps patients with anxiety, especially if the treatment delivery is done on right side of the hemisphere. We see also when we do TMS treatment for depression, and if someone also has a high anxiety score, we also do additional treatment on right side for anxiety. And TMS, there are some data which shows TMS is helpful for PTSD. However, more research needs to be done about specific protocol for PTSD. And our literature suggests that most promising results were high frequency 10 hertz, where someone used 24 session with 3000 pulse protocol on right prefrontal dorsolateral cortex. Not the left side is for depression, but if you do it on right prefrontal dorsolateral cortex, that's where the most study points out toward some benefits of TMS in treatment for PTSD. TMS is also been studied for chronic pain and cognition. Cognition is memory, concentration, those function. It improves in depression studies. There are improvement in cognition in patients with head injury and strokes. Studies suggest improvement of cognition in patients with PTSD, and there are ongoing clinical trial on cognitive improvement in patients with schizophrenia and Alzheimer's disease. Once again, I want to mention that TMS currently do not have any FDA approval for any of the other disorder. These are just some of the active clinical trial data where they have worked on uh, measuring the cognitive ability in other disorders, and the results are uh, fairly positive. And for chronic pain, somebody with fibromyalgia, burning mouth syndrome, chronic neuropathic pain, CRPS, any of you have heard of it, it's an awesome chronic regional pain syndrome. TMS has shown some positive results. Again, they are studying Parkinson's disease and migraine. Now, this is just some of the side effects and contraindication for TMS. So someone with headache is one side effects. A lot of patients do experience headache, and it's because the treatment comes like this. So there's a scalp irritations. But most patients do well if they take ibuprofen or Tylenol before the treatment or after. And we haven't had hardly any patient who drop out of the TMS treatment because of the headache. And generally, the headache gets better after third or fourth treatment. And then there is definitely a scalp irritations, and then the third is a seizure risk, which is less than 1%. Now, in some clinical trial, they have shown the seizure risk is equivalent to using antidepressants too. But somebody with active seizure, active conversion disorder, should not be looking into doing TMS until the seizure is under control with treatment. And then someone is with aneurysm clips or brain, someone with deep brain stimulator, electrodes to monitor their brain activities. A lot of patients have that for Parkinson's and other disorder treatments. If there's metallic implant in your ears and eyes, stents, stents after the surgical procedures in your neck, bullet sharp nails near the head, and then facial tattoos with metallic and magnetic sensitive ink is contraindications. Though we have had a couple of patients with TMS treatment with facial tattoos, and tattoos was not as close to the treatment sites, and they had done well. So that is one contraindication we can reevaluate on case-by-case basis. But other metallic devices or objects implemented on or near head is also contraindicated. This is again the PHQ-9 score, and this is the scale that monitors clinical depression intensity. If your score, and all of you can also take this test at home, if your score is 0 to 4, it's none or minimal depression, no need for treatment. If someone's score is 5 to 9, it indicates mild clinical depression. Someone with 5 to 9, PHQ-9 needs to have a close follow-up with their primary care physician or with the therapist. Somebody with 10 to 14, where depression is considered moderate. So those patients who take the test, and if depression is in a moderate range, then they should definitely consider medication management, psychotherapy, TMS, or some sort of a treatment for their mental health issues. So this is, and then 15 to 19 is considered moderate to severe, and then more than 20 is a severe depression. If your loved ones or anyone you know has more than 15 PHQ-9 score, I would highly urge to take it seriously and get help. Because if you have score in that range and if you don't get help, you may have a cascading effect about depression going down. So 15 and 19 is moderate to severe, and again 20 and above is severe. And then for those, TMS, ECT, IOP, more intensive type of treatment would be more appropriate. And this, okay. And now I'm going to invite Katrina, our lead TMS technician. Welcome, Katrina, and she's going to talk about all our TMS teams capture scores for the patient, and they kind of monitor the score, and she will talk about statistics and some of the logistic aspects. Katrina, welcome.
All right. So in total, we've done 270 patients course. This is the PHQ-9. It's a 9-question questionnaire that we get patients to fill out weekly. And we break it up into 3 categories. Response will be 50% or greater improvement. Remission will be 80% or greater improvement. And then other, which consists of less than 50%. And that we see this from the first day of treatment score to the final treatment score. So for the PHQ-9, we have been seeing 69% as response, 29% remission, and then 31% is other. We also do BDI-2, which also will show depression. And with that, we've been doing not as long, but we have 199 patients that we've done those scores for. And we are seeing 61% response, 27% remission, and 39% as other. And then I'm going to have one of our technicians, Tamaya, go over. We also have been keeping track of our anxiety scores, as a lot of our patients also suffer from anxiety, so we add on that treatment.
I'm Sam. This works.
So we do go ahead and get scores about anxiety for each of our patients so that we know if the anxiety treatment would be beneficial to them. As far as our Beck anxiety inventories, which was a questionnaire that we did use previously, 61% saw response, which is a 50% or greater improvement. Remission was 26%, which was 80% or greater improvement, and 39% was other, which was less than 50%. The Burns anxiety inventory is what we currently use to scale anxiety. For this one, we have also seen a 69% response, again, 50% or greater improvement, a 17% remission, and a 31% other. So we have seen really good results as far as anxiety treatment goes, and we do add on this treatment a lot of times because depression and anxiety can go hand in hand, and we do think that it is beneficial a lot of times for our patients. So here are some graphs about our PHQ-9 scores. You can see that all of them go down. We've had a couple back up towards the end, but this could be situational. But we do see a greater decrease. Where the line is the last treatment, and everything after that is their post-treatment scores. So you can see a lot of times they do decrease even after treatment has ended. Here's another one for you. So here are our anxiety graphs for Beck's anxiety scale. Again, you can see that they decrease pretty greatly. We see a lot of good results with this one. All right, I'm going to go ahead and hand it over to our other tech, Lena, who is going to talk a little bit more about what it entails.
Hi, so the first step to get TMS treatment at Siyan Clinical would be to get a psychiatric evaluation. And with this, we'll confirm the diagnosis and also see what medications have been tried. The next step is to get a benefit inquiry, and that's followed up with authorization paperwork for the insurance companies. A TMS course is a total of 36 sessions. This would be 5 days a week. And then the last 6 treatments are usually tapered over a 2 to 3 week period. Most sessions, the time is between 18 and 20 minutes. It depends on intensity. As far as insurance, we do take most insurance, and most of the insurance covers TMS with a prior authorization form that is filled out. The policy usually involves a diagnosis of moderate to severe treatment-resistant depression, along with 4 or more medications that have to have been tried during this time. Then I'll go ahead, hand it over to Dr. Shaw. Thank you.
So thank you, TMS team. So there's a lot needs to be done about TMS, and a direction needs to be. We are anxiously waiting for TMS to be approved for patients less than 18, so for our children, And I would be very happy on the day that TMS is FDA cleared for adolescents and children. This is one treatment, as I've said, has no systemic or long-term issues in most clinical trials, and I think it would do a wonder when it gets approval. We're also looking at trial data on TMS treatments and FDA clearance for PTSD, generalized anxiety disorder. Actually, it has been already been approved for OCD, obsessive compulsive disorder, a different device through TMS has been approved for OCD too. So that has been cleared. And then the fibromyalgia is another area where they have been looking into TMS treatment. And now they are also looking at short course of treatments. We at Siyan doing 36 conventional standard protocol, but they have been doing research about if there is a way we can do rapid, which we call as theta burst, rapid sequential stimulation with TMS, and we do multiple of those treatment sessions in a day's time, and that is another area of research that is evolving in TMS. And so there is a lot that we are looking forward to for future directions. And with this, I would conclude our TMS presentation, and I would now invite my colleague Jessica to speak a little bit about the other treatment modality, nasal esketamine or Spravato. Jessica, welcome. Thank you.
Hello, everyone. I'm Jessica. So yeah, let's talk about nasal esketamine. Again, myself or Dr. Shaw, we don't have any financial relationship with the manufacturer or any commercial product or device that may be discussed in this presentation. So here we are going to discuss some off-label uses for ketamine and experimental or investigational use of drugs or devices, but mainly esketamine use for major depression and with or without active suicidal ideation. So for today, our objectives are to list the current treatments that may be used to help individuals with treatment-resistant depression, describe the mechanism of action of esketamine, discuss the benefits, risks, and appropriate use of esketamine, and discuss some of the logistical processes around REMS enrollment, scheduling, and monitoring. And we'll get more into those topics later. Let's go on. Um, there we go. Okay, so Dr. Shah has already talked quite a bit about treatment-resistant depression. But here, for esketamine purposes and for some of the studies that we're going to talk about, the definition of treatment-resistant depression is going to be a failure of 2 or more antidepressant therapy trials that were of adequate duration, meaning you were on an antidepressant for at least 6 weeks and it did not work for you. And the definition of failure is based on a decrease of the MADRS scale, the Montgomery-Åsberg Depression Rating Scale, which is a little different from the scale that was already discussed, the PHQ-9 and the BDI-2. So moving on. So we're going to talk about like 2 kinds of ketamine here. The first one is traditional ketamine. This form of ketamine has been around for a while now. It's used for anesthesia, pain management, and years ago, it was figured out that it can be used at sub-anesthetic doses to treat depression. So this is an off-label use. It's not FDA approved to be used for depression, but it is currently being used by certain clinics throughout the country. So basically, it's been used to treat depression for people with depression that hasn't responded to traditional treatments, which is going to be your oral antidepressants. So ketamine as a treatment for depression is available in different formulations, lozenge form that you can take under your tongue, intramuscular injection, intravenous IV, or a nasal spray. And this is esketamine, what we're going to be talking about mostly in this presentation. Okay. So traditional ketamine is basically a mixture of 2 of the chemical. So this might sound a little confusing, but it'll make sense. So you have both an S and an R form of ketamine within the ketamine drug. So basically it's, a mirror image of each other. So you have the R and the S and they're mirror images. So why is that important? Basically because when we talk about esketamine, we're only talking about the S form of the S hand, basically. So esketamine, the FDA approved version of ketamine, is basically part of the original ketamine, but not the whole drug. And this is important because the esketamine binds to this receptor, the NMDA receptor, more potently than the R form does. So by having a drug that's only esketamine, you have more potent binding at this NMDA receptor, which is important for the mechanism to help treatment-resistant depression. And just of note, so the NMDA is one receptor that's involved in treating depression. Other receptors that may be influenced by ketamine are opioid receptors, like mu receptors that certain opioid drugs bind to, like oxycodone, as well as some AMPA receptors, which are kind of a complicated mechanism, but that's one of the sites of action. All right. So we mentioned that ketamine binds to the NMDA receptor. And basically, what this does is the ketamine binds to this receptor, then it releases glutamate, which is a neurochemical neurotransmitter, whatever you want to call it. It's released in the brain, and the downstream effect, there's this whole cascade of things that happens. But basically, the end result is you get synaptogenesis, which is the formation of new synapses and increased connections between the brain cells. So ketamine or esketamine basically have these downstream effects on growth of brain cells in the nervous system. And this is just a little comparison of ketamine compared to other more traditional antidepressants. So here we're talking about ketamine in relation to some of the, antidepressants here. We have the SSRIs, which is the selective serotonin reuptake inhibitors, such as your Prozac or Zoloft or Lexapro. Then you have the SNRIs, the serotonin norepinephrine reuptake inhibitors, which is drugs such as Pristiq or Effexor or Cymbalta. NDRI is really only one drug, which is Wellbutrin. Serotonin modulators, some of the newer antidepressants. And then the TCAs, or the tricyclic antidepressants, are a little bit older, but they include things like amitriptyline, nortriptyline, doxepin. So when we compare those to ketamine, the onset is much more rapid with ketamine. We're talking like hours, at earliest. Sometimes it can take days or weeks, but a lot of folks do find that benefit, shortly after the drug is administered. Whereas with antidepressants, you're looking at weeks. Many of you folks know that basically at least 2 weeks to get a benefit from one of these, anywhere from like 6 to 8 weeks to get the full benefit. The frequency of dosing is also different. For ketamine and esketamine, we have a very specific protocol for dosing the medication. Essentially, and I'll go over this more later on, but essentially the first week, the drug's administered 2 times, then 4 weeks later it goes to 1 time a week, then it can go as infrequently as twice a month. With the other more traditional antidepressants, you're looking at daily, taking a pill daily. The route of administration is different. Traditional antidepressants are oral, whereas ketamine can be IV, intramuscular, oral, or intranasal. What's kind of nice about ketamine and esketamine is that they do have this novel mechanism of action. The focus, historically has been more on the monoamine neurotransmitters, which is these 3: serotonin, norepinephrine, and dopamine. But some people don't necessarily respond to modulating these neurotransmitters, and that's where ketamine is nice, because it has a whole different mechanism, essentially, that's mainly achieved through the glutamate release. So something new and different. Right, so let's talk specifically about esketamine, or Spravato is the brand name. So esketamine is the only FDA-approved ketamine treatment for treatment-resistant depression. And it's indicated for treatment of treatment-resistant depression, but also major depressive disorder with acute suicidal ideation. So, so, you know, there are pretty strict guidelines under which ketamine or esketamine should be delivered to patients. First of all, patients receiving ketamine or esketamine should, of course, be under psychiatric care. And it's really the treating psychiatrist or nurse practitioner who determines whether, you know, whether other treatments have been appropriately administered, and monitor treatment outcomes if, you know, if the provider decides that this is the best course of action for a patient. So in terms of administration of esketamine, the setting is pretty important. You know, we only administer it in certified medical offices that have been given a prior authorization and approval for the patient through a risk registry. So that was mentioned earlier. That's the REMS program. I think another slide comes up with that. The protocol is basically that the patient is going to self-administer the esketamine and then is monitored on site for 2 hours. Again, is intranasal, and we'll show you the device shortly here. But basically, you know, the patient monitors it themselves, then, you know, they can kind of chill out. Here we have a nice treatment room where, you know, the lights are kind of dim and we have a fountain and it's quiet and relaxing. And sometimes patients like to listen to music or, you know, close their eyes. But yeah, basically kind of hanging out for 2 hours. We're checking your blood pressure. And then after 2 hours, you get a ride home. So in terms of dosing, there's 2 different dosages for the esketamine devices. The first one is 56 milligrams and the second is 84 milligrams. Obviously, we're going to start with the lower dose. So we'll do, for the first 4 weeks, it's going to be dosed twice a week. So we'll start with the 56 milligrams. Then it's kind of up to the provider whether or not we're going to go up to 84 milligrams or stay at the 56. Ultimately, it's better to go up to 84 because results seem to be better in the data. But, you know, you want to make sure the patient tolerates it as well. So beyond the 4 weeks on week 5 through 8, the medication is only administered once weekly. And this is kind of, so the first 4 weeks is what we call the induction phase. That's kind of like, you know, like front loading the medication into the system. And then beyond that, we're going into a maintenance phase to kind of extend the effects. So weeks 5 through 8, it's going to be once a week. Then week 9 and after, it can either be continued once a week or once every 2 weeks, depending on the judgment of the provider. And then there's also like a short-term dosing plan, which I believe is more for major depressive disorder with suicidal ideation. So generally, esketamine is going to be used once someone is already taking an antidepressant, but it can also be used in people who are not taking an oral antidepressant. Okay, so now we're going to talk about some of the data. Basically, there were 3 short-term studies done for esketamine. It's a little confusing. I'm going to try my best to explain it, but if you're confused, I'm going to have a little summary slide at the end. So essentially, the first study looked at the endpoint was the mean change in the MADRS scale. That's the scale we talked about on the first slide. So it was a 28-day study. So there was 3 arms. The first one was patients receiving esketamine and the lower dose of esketamine and an antidepressant. The second group was higher dose of esketamine plus an antidepressant, and the third group was an antidepressant plus placebo. So as you can see on the results graph, basically the esketamine groups had a greater change in the MADRS score. So their score went down more, meaning their depression was better treated. You could look at it that way. And then here's it in a graph form. The percentage of patients who received response from the esketamine, the darker green is the low dose and the light green is the higher dose. And, in all groups, the patient was receiving an antidepressant in addition to esketamine or not. So, quite a few folks, had a response to the treatment. Lesser had remission, but that's harder to come by. But remission for this study was a MADRS score of less than or equal to 12. Okay, and this is a second study, looked at esketamine plus an oral antidepressant in terms of the change in the MADRS scale over time. So basically similar results to the previous one. Just more of a response with the esketamine versus without. And in this study, there was a greater chance of remission. And this was kind of nice. In the third short-term study, they looked at treatment in an elderly population, so folks who are 65 or older. And similarly, they looked at the change in the MADRS score. And it's kind of interesting, as you can see by the graph, it looks like it took a little bit longer for them to have a response. It didn't happen until around like week 22 that the two groups have separated more. The top is the placebo and the other is the esketamine. And yeah, just the same study in terms of graph form, pretty good response compared to placebo and remission compared to placebo in the greater than 65 age group. All right, to summarize those 3 studies, the first study was done population from ages 18 to 64, and basically esketamine plus a newly initiated antidepressant resulted in clinically meaningful and statistically significantly greater improvement in depressive symptoms compared with standard of care, which is considered an oral antidepressant plus placebo. And then the adverse events that were predominantly seen were on the day of dosing the esketamine, and they were transient and resolved within 90 minutes of the dosing. So that's not so bad. In the second study, there was fixed dose of esketamine plus an oral antidepressant and there was a clinically meaningful treatment benefit in the improvement of depressive symptoms, but it did not reach statistical significance. So, meaning, there was a change and a benefit, but it didn't quite get to the point where we could say it kind of was significant. It was statistically significant. So there could have been like other things to explain the results. And the final study, again, with 65 years and older population, found that there was meaningful treatment differences in the MADRS score at the end of 4-week induction phase, plus a newly initiated oral antidepressant compared with standard of care plus placebo. And the safety profile was consistent with a younger population. So basically, if a provider decides to use this treatment on someone 65 and older, they can expect a similar safety profile. That's nice. Right. So there was 2 long-term studies as well. And basically, for these 2, there was like an initial induction phase of 16 weeks. And then the study participants were broken up into those who remitted and those who responded, and then kind of broken up again into those who got the antidepressant plus a placebo, and those who got the esketamine plus an oral antidepressant. And basically, as you can see here, it's kind of measuring like the number of patients who did not have a relapse, and you can see that there's more patients who are relapse free in the esketamine group. The first one is the stable remitters, and the second graph is the stable responders. And this is, I believe, the final study, which I think there's better summary of that here. So in the second study of the long-term effects, there's a 4-week induction phase and then long-term treatment with esketamine together with an antidepressant, and it included the elderly patients. Then for the first long-term study, there was continued treatment with esketamine plus an oral antidepressant, and this demonstrated statistically significant longer time to relapse versus treatment with an oral antidepressant. So longer time to relapse. Adverse effects were mild to moderate, and again, were generally seen only on the days that the drug was dosed, and then they pretty much resolved the same day. And talking about adverse events, what mostly came up in the studies was blood pressure increases and dissociative symptoms or perceptual changes. And these began shortly after the start of the esketamine dosing and then peaked at 40 minutes, but then were resolved by 1.5 hours later. So good to know if something like this does come up, it's only going to last an hour and a half, essentially. And then there's no reported cases of interstitial or ulcerative cystitis, which is like a bladder disorder, which I guess has come up in some folks who use ketamine more chronically as a drug of abuse, I think is where that's mostly seen. Well, here's the frequency of adverse effects of esketamine. So looking at, anxiety is about 13%, blood pressure increases are 10%, dissociation is 41%. And by dissociation, it's kind of a sense of feeling unreal or feeling like the environment's unreal. So that is, that is a risk that can come up for folks. Dizziness is 29%. And hypoesthesia is basically like a lack of feeling, like numbness. So that's 18%. Then some lethargy, nausea. So nausea is a risk. We do recommend to our patients that they don't eat for at least 2 hours before treatments. But only 9% of the time does the nausea result in vomiting. And if it happens, it's usually short-lived. So, and finally, sedation, vertigo, and feeling drunk. So there's that. So these are contraindications, meaning, if these show up, we're not going to pursue esketamine treatment. Any kind of risk of aneurysms, whether it's like a thoracic, abdominal aorta aneurysm, or some valve abnormalities. Any history of intracerebral hemorrhage, or of course hypersensitivity to esketamine, ketamine, or any of its excipients. So any allergy to those. And now, so Ariana and Itzel are gonna come up and talk about the devices.
Hi, my name is Itzel, and this is Ariana. We're the Spravato specialist technicians. So if you do choose to continue or start treatment with Spravato, we will be your MAs. We'll be there monitoring you. So I'll get started first. I'll be speaking about how it starts, the beginning phase of Spravato. So this is the insurance. That is a lot of a question whether Spravato is covered by my insurance or that. So first what we do, the first step that we do is we do a benefits investigation. So we investigate whether Spravato is covered by your insurance. And then let's say it is, and then we do an authorization for your treatment. Don't worry, all this big word stuff, we deal with that, not you guys. And then we submit a response, and then each patient and each insurance for that patient is different. So it can take about a week or two to happen for us to get that response from the insurance. But like I said, once again, each patient and each insurance is different. And let's say, for example, we do get an approval. We can begin treatment at least as soon as we enroll you in REMS. So let's say, for example, we receive that your insurance is covered and we enroll you, you can start treatment like that. So it all just depends. But like I said, each insurance and each patient is different. But let's say, for example, your insurance denies it, denies treatment, we appeal it. Sorry, that takes about 7 to 30 days as well. Let's see, next thing. So this is our checklist for the administrative staff. So we do that. So first, we have to confirm that you are diagnosed with major depressive disorder or treatment-resistant depression. And then we have to see that you at least failed 2 trials of antidepressants max before. And then we have to verify, obviously, that your insurance is covered or not. And then we review with you the guidelines of esketamine, and then we enroll you in REMS. And then we show you kind of how it works, and then we schedule you. Like Jessica explained in the beginning, you will be seen twice a week for the first 4 weeks, and then once a week, and then after. But during this whole process, we're with you the whole time. And then we do reminder calls, obviously, to remind you that the treatment is happening twice a week. And then we'll let you know when it's going to be changed to once a week with a provider as well. And then we do a urine drug screening as well. And then the day of administration, Jessica does speak about, or she just spoke about, because it can cause nausea and vomiting, we do recommend that you don't, like you avoid food like 2 hours before administrating, and then 30 minutes, we recommend that you don't drink like water or like soda or anything like that. And then let's say, for example, you take like an allergy medicine that's nasal, we recommend or we require that that be done at least 1 hour before you start treatment. And then that's all for me. But then here is Ariana, who will be explaining a little bit of the steps that happen during.
So I'm going to talk about the device. So I'll show you the device for Spravato. It kind of looks like one of your normal little nasal sprays. So it looks like this. It's self-administered. We do have you come in. We'll have you blow your nose first, and then we'll have you administer this to yourself. So how it works is once you press it down, one of the little dots will turn white, meaning that you administered the medication. And then green means that there's one more in there. And then once you do it, as long as both of them are white, you took the medication. And then, so during the process of us monitoring you for 2 hours, we do take your blood pressure because the medication does elevate your blood pressure a little. So if you do have blood pressure issues coming into this, it may elevate it a little, but you could still take your blood pressure medication, no problem. And then, so we'll take your blood pressure at the beginning and 40 minutes after the medication, and then we'll take your blood pressure again, probably about 15 minutes before you leave. And then, so we do have a little wait time. So the 56 milligram device, it's 2 devices. Once you do the first device, you have a 5-minute wait. We'll have you guys wait like 5 minutes, and then we'll administer the second one. And the same with the 84 milligrams. It's just a 5-minute wait in each device. How it's administered is like any nasal spray. We have you tilt your head back 45 degrees, spray it, and then we'll have you wait. And that's basically the same thing about administering. And it's kind of the same thing what I just explained. And then, like I said, during and after administration of each treatment session, the patient must be observed for 2 hours. So we do require that you get a ride. We don't want you driving because it is a controlled medication, so please don't drive. So at least get a ride. And then we advise that you do not make any major decisions. Don't go out by house and make any decisions after you do your treatment. I have seen that patients after their treatment, you could get kind of sleepy, or at least fatigued for the rest of the day. But that's pretty much it for administration. We just monitor you for 2 hours, check your blood pressure, and we advise you not to eat or drink a couple hours before because we don't want people to get nauseous or anything like that. And then this is our information. If you have questions about Spravato or TMS, you could call our office or email. These are our email addresses, and I think that's it.
Does anybody have any questions for Dr. Shaw or Jessica? So we did receive some questions over the from the virtual attendees. Dr. Shaw will go first, and then Jessica will have a couple questions.
Before I take questions from virtual attendee, any of the group here has any question about TMS or Spravato? Sure.
I have one question.
Uh-huh.
You said something about headaches. Is it dangerous for somebody that gets migraines?
It's not dangerous, and we have had many patients with migraine headache receive treatment. On the contrary, a different protocol for TMS is also used to treat migraine. So not the one that we are using, but headache can occur, but most of the headaches that occurs with TMS is from the scalp irritation. So if you take Tylenol or ibuprofen, it gets better. And most patients, what we have seen is headache, even if they experience after 2 or 3 treatments, the headache is better. And I can speak that we have had nobody who discontinued treatment because of the headaches or side effects. A good question. Thank you. Okay.
On esketamine, that sounds like it's like ongoing. Never, and your antidepressant.
Generally, so what we have for our protocol here is you would have the induction phase where you get it twice a week, then you get the awakening phase and the maintenance phase. But generally the evidence supports 16 treatments thereabouts, and then seeing, whether, and then, if remission is achieved, great. Give it some time without, and obviously continue the oral antidepressant, but essentially, yes, you're not taking it indefinitely.
Thank you, Jessica, for explaining. And just for audience's reference, I have just pointed the slide that Jessica had presented. So treatment maybe for first 4 weeks, we are doing 2 times a week. And then from week 9 onwards, like Jessica mentioned, this once a month or clinical needs that evolve. But clearly, this is not a treatment for indefinite period of time. And then once somebody does well or have substantial improvement, we could revisit it after 6 months if the episode comes. Thank you, Jessica. Yes.
TMS before and you didn't have significant results, is it worth trying it again a year or 2 later? Maybe some different outcome?
It's a good question. I think it all depends upon when you do a psychiatric evaluation. So there are so many factors we need to assess. First, the level of depression and other situation in which you have done TMS, what protocol they may have used, what were some of the issues around the depressive symptoms and TMS and so forth. So yes, it may help. It may also not help. So it's very hard to tease it out until we do a thorough assessment. Because which device did you use? That's another confounding variable. So, but potentially, and then there are 2 other parameters. When if depression, whether improved or not, what is the evidence of that? Is it by the scales that you did or your subjective feeling of well-being? Because all these questions are to be considered for clinical reasons and also for insurance authorization.
Oh,
Yeah. All right. Thank you. Good question, though. Yeah, Dr. Mans.
Why would you use 2 different depression scales?
So I think we are using the same scale. We are using PHU-9 and BDI for both treatment modalities measured. Madras,
Yeah.
maybe I'll have Jessica answer that.
It was just for the research studies that were done, they used the MODIS instead of I guess it's just kind of a preference.
Preference in the trial. So when they did a trial, there are 2 scales. One is subjective rating scales, how patients rate their scales. So PHU-9, BDI are subjective rating scales. There are other scales for depression, which are objective rating scales, where clinician administer those scales. So Madras, MD, these are the scales which are clinician administered or objective rating scales. And in clinical research, they want to see both subjective rating scales and objective rating scales. For our purpose of treatment here, we are only using the subjective rating scale, what patients experiences. That's why we are using only BDI and PHU-9 for both treatment. But if we had to do research, the IRB or FDA would ask us to use objective and subjective. Make sense? Okay. I'm also going to take some question from the audience, and I'm going to read out loud this question. The first question is TMS used for bipolar disorder? Is there any evidence that it can precipitate manic episode? So the question here is sort of tricky. Yes, the answer to that question is yes, TMS can precipitate a manic episode if you have a diagnosis of bipolar type 1 disorder. It is less likely to precipitate a manic episode if you have a bipolar type 2 diagnosis. And now, TMS is currently not FDA approved for the treatment of bipolar depression. However, there are numerous clinical trials in bipolar type 2 depression where the predominant episodes are depression in bipolar patients. TMS is being used. TMS is being used in various TMS centers. But what we have seen is insurance companies generally do not authorize TMS for bipolar depression indication. So if you have a bipolar diagnosis, it may be a good idea to do a psychiatric evaluation, confirm the diagnosis, and then go for a treatment. If you have a bipolar type 1, which is where you had a full-blown manic episode, it may not be a good idea to pursue a TMS at this time. That was the first question. And then Jessica, you had a couple of questions you want to take on, and maybe from here, so they can see you.
Okay. So this one is, given the interaction with an opiate receptor, is there any evidence of it precipitating substance misuse in patients? That is a good question. So I think, you know, with esketamine, we have to keep in mind that it's not directly binding to one of the opioid receptors. It interacts with it a little bit differently. So you're not essentially getting the same effect as you would with an opiate. And as far as I know, there's no evidence that using ketamine in a clinical setting for treatment-resistant depression can precipitate any kind of substance misuse. That being said, though, we want to, it is, ketamine can be a drug of misuse.
Yeah.
So we do want to be aware of that when assessing patients, and anyone with a history of substance misuse. We want to make sure that individual is in treatment and has, a good amount of time of sobriety before undergoing the treatment, I would say. Anything you want to add, Dr. Shah?
Yeah, I think very well said, Jessica. This is a tricky question. We would say if somebody has an active substance use issues, nasal esketamine treatment may not be the best choice, like what Jessica has mentioned. Now, if you're using nasal esketamine for clinical depression treatment, can it cause addiction? The likelihood is very less, if it's used for depression. If you are using nasal esketamine in a treatment centers where you are monitored, you are being counseled, and the use is appropriate as FDA indicated those, then the addiction potential is very less. Once again, the treatment nasal esketamine is used in clinic right now. It's not for in-home use. So then that also deters somebody for going on to that path, However, the things becomes more trickier or problematic when you go for off-label use of nasal esketamine. You go to one of the centers where they will use nasal esketamine for a long period of time without having appropriate clinical settings to observe, monitor, and counsel our patients. So that was a long answer. Yes. Thank you. And the second question was, esketamine, do you have to use twice a month forever? And I think Jessica already answered, and I'm just going to read not forever. At least so this is the course of treatment that you see on the screen, and then maybe a maintenance treatment, and then we have to see what needs to be done for managing the depression further. Yes, please.
For the first 1 to 4 weeks. Where's our gap?
Usually, yes, there has to be a gap in between. We'll do, or there has to be a gap of time of at least a day in between. Here, we're usually doing it either like Monday and Wednesday or Tuesday and Thursday. And it's, I don't think there's any evidence about doing consecutive this.
Yeah, it may be a little much for our patient to do consecutively because it's a sedative drug and there are driving restrictions. I mean, you could theoretically use it if there are extenuating circumstances, but that's not what we recommend. We recommend, like Jessica has mentioned, maybe a 1-day gap between treatment sessions. So your brain has a time to recoup, and then you are less susceptible to side effects like dissociation, sedations, cognitive issues, and in a rare form of hallucination. So having a gap is always a better option. Yes. Okay, what's the question? Hi, Nisha, you can unmute and ask the question. Yeah.
Yeah, I was just wondering, if you're taking a lot of antidepressants, is TMS a good option? That's one thing I was wondering. I was also wondering that, is it okay to have alcohol consumption in moderation, even if you're taking like Zyprexa and antidepressants and stuff?
Okay, both good questions, so the question from the audience was, if you have used multiple antidepressants and had a prolonged, is TMS a good choice? I would say yes, it is a good choice. It is a good choice for people with treatment-resistant depression. That's what the TMS got an FDA approved. So if you have tried more than 4 antidepressants, TMS is a good choice. Now the second question is about using alcohol and psychotropic medication along with the TMS and other treatment modalities, Nisha. So for that, I would say alcohol is a depressant, it depresses brain, and we are trying to activate your brain with TMS, or we are trying to activate your brain by NMDA receptor antagonism by Spravato. So if you use alcohol, maybe 2 or 3 times a week, no more than 1 glass of wine, you're okay. Yeah. But if you use more than that, then what we are doing together or work together is not going to yield the results that we are looking. So that's what I always say. If you're using heavy cannabis or heavy alcohol consumption, we are kind of not activating the neurons the way we should be with the TMS and other treatment modalities. All right. And you can continue your conventional, whatever antidepressants or your current, not conventional, your current antidepressants along with both esketamine treatment or TMS treatment. We highly recommend that you don't stop your current treatment. Yes.
Does Medicare cover any of this?
Yes, Medicare cover both the treatment. And for TMS, I must say that our technicians and our team has done a good job. We are one of the very few centers for TMS who takes Medicare in Bay Area. And Medicare will cover both the treatment.
Okay, then, what is the question? When you're doing the study, do people quit doing it because of side effects? I mean, like for me, I've never done suicide stuff like that, so I don't know what happens, but the idea of like having a hallucination or something like that is enough. So I'm just wondering, like, if anybody quit that or.
Well, first of all, I will say like hallucinations or paranoia or delusions, anything like that isn't common with the ketamine treatment. I mean, some consider it a psychedelic drug, yes, at the doses it's used at. So there might be some like some perceptual changes or some changes in your perception of time, or dissociation, but it's generally not to the level of full-blown psychosis. And yeah, here we haven't had anyone stop due to side effects. Yeah, it seems very, so far, people tolerate it very well. And, you know, main thing we might see is like a little bit of drowsiness afterwards, or, you know, brighter mood sometimes, which is a good side effect. But yeah.
Thank you very much. Indeed, we have not had anybody with, say, close to 6 patients, and each patient may have about 14 to 16 sessions. And nobody had, not even in one single instances, had a psychosis. Jessica well described the common issues in terms of sedation, some sort of a brightened mood or perceptual disturbances for that 2-hour period. And that is the precise reason we want to monitor immediately. We want to take the blood pressure. Any other questions?
Can I ask you a question?
Sure. Okay, then.
You talked about ketamine being a racemate drug.
It's a racemic mixture, as in there's two, well, I don't want to get too technical, but we say like it's a racemic mixture, meaning it's comprised of 2 enantiomers, which are like the esketamine and the R-ketamine.
The enhancement.
Well, the esketamine, they're both pharmaceutically active.
Both of them.
Yes.
One's more potent.
One is more potent at binding to the NMDA receptor, which is supposed to be like one of the main sites of the antidepressant effect of ketamine. But you know, yes, the R form also does that, and other things that maybe you don't know as much about. But it's been yeah, it's a tricky question. So I think probably the drug manufacturers chose the S form, the S enantiomer, because it binds more potently to that receptor.
So the drug is solely the S enantiomer?
Correct. Yeah. Yeah, it's like S-ketamine, like ES ketamine, like S-ketamine.
Okay. Drug is not
just the one. It's just the one. Yeah. Good question. Yeah.
Thank you, which is good question.
Just quick one. So what is the way for if you wanted to start with a ketamine treatment or you want to do enough treatment? What do you guys have
Can answer that question in terms of it all depends upon which treatment and the insurance that you have. Generally, for TMS, we have been able to schedule patient in, and I don't want to speak for our technicians team who are the master, but I just want to say generally, let's say 2 to 3 weeks for TMS treatment. And for esketamine, again, I don't want to speak for our technicians and their ability to get everything done, but generally speaking, it's about 2 weeks to 3 weeks too. Is that right, team? Is that a right estimate about? All right. I see a thumbs up there. So yes, 2 to 3 weeks. Yeah. Any other question? If you have more questions, do not hesitate to contact us. If you are interested, please let them know for psychiatric evaluation, because that's the first step before we enroll anyone. I want to thank our lovely audience. You all had great questions, good presence. So thank you so much. And I want to acknowledge before we end all our TMS technicians, Spravato technicians work, and a round of applause for that their work. And along with them, three other important people in the room. There is a Helen, who is our technical guru. Helen, raise your hand. And she is the one who set up and did all of this. We have Bhargav, who is our IT and technical sort of advisor and executioner. He's virtual right now doing this presentation. And I have here Amanda, our health service administrator, who really did a good job in organizing this event and all of the logistics. And last is Lisa, our office manager, who kind of gets the clinic flow for this treatment modalities and other things work. So Lisa and Amanda's contributions also to be. So thank you so much. Okay. All right. Look forward to it.
Go ahead and take them as you want, as you need. We also have some